Hi, and welcome back to the Middling Along podcast. I'm delighted to have as our guest this time Dr. Katie Barber from Oxford Menopause. She launched the private service about 18 months ago. She also does work with various businesses, so corporate services, and that's how we've gotten to know one another. She's just delivered two excellent sessions to the company that I work at in my day job, because believe it or not, this is not my full time job. So, yeah, Katie, welcome along to the podcast. Thank you for joining us.
Thanks for having me, Emma.
So, tell us a little bit more about why you decided to set up Oxford Menopause and sort of some of the rationale for doing that. Why is that something that's needed?
Well, I pretty much now live, breathe, and sleep women's health and menopause, and it's a passion of mine and has been for a long time. I started off in my GP training having a real interest in women's health, and then ran the menopause service at the John Radcliffe Hospital in Oxford for a few years before moving into community gynecology, which is now where I work. So I am completely passionate about making sure women have access to specialist advice, but also time to listen with a specialist about their concerns. And I think really the reason I launched my private service was just I felt I was really struggling to give women the time I wanted to give them on the NHS in a small time frame. As a
Mm.
GP or even in the community clinics. And for some women, menopause is quite complex. It's not a standard presentation that they can easily access help for. And having the time and also dictating how long I can spend with women and the type of advice I can then explore in detail with them was just really a revolution for me and allowed me to have so much passion for what I'm doing. I feel it was really rewarding. So that's really why I launched that aspect of the work I'm doing. And that kind of led on to the teaching side of things. So, teaching is something I've always done. I've taught medical students, junior doctors, consultants, nurses in lots of different roles. And teaching is something that I love to incorporate in my weekly working life because sharing knowledge and empowering others to go out there and also help women is key. And the more we can disseminate that knowledge and expertise, so that even if it's just a few little nuggets of information that are remembered by a junior doctor for years to come and then potentially influence their life as GPs or hospital consultants, for me, that's worthwhile. So I started off doing a lot of medical teaching and then realized that it wasn't just about educating my healthcare professional colleagues, but also about sharing expertise to allow women in general to be empowered about the knowledge for menopause, and also understand more about their own health issues. A lot of the time, menopause management is something that you can be quite keen and involved in yourself, and changes can be made quite simply through lifestyle changes and diet, exercise, etc., which I'm sure we'll come on to. But it wasn't just all about hormone therapy and medication, and a lot of my consultations cover that area. So, really, the reason I've started to do more and more teaching is to try and share expertise, share knowledge, and really allow women to be empowered to help manage their menopause and seek the right advice from the right person.
And I think it's probably fair to say that the sort of the work that you're doing, going and talking to groups of people within business, within different organizations, has really taken off as companies have realized that this is something that they can't really afford to ignore. And there's sort of that general kind of groundswell of popular, I was going to say not enthusiasm, that's probably the wrong word, but more and more interest in this as a sort of a subject. And certainly from the point of view of HR policies, workplace policies, and workplaces realizing that they kind of need to really up their game as far as this subject is concerned.
Absolutely. And I mean, I have to say, I've had two more emails today from companies saying, look, could you come and do some education? So, word clearly travels fast. And I'm not particularly social media savvy, but the knowledge out there that these educational topics are key is just so important. There's some fantastic organisations that I've taught in who are clearly wanting to support and empower their staff. As women, we form a huge proportion of the economic workforce in the UK, and menopause can affect quite a lot of us adversely for a lot of our working lives. I mean, we spend probably half our lives now in peri or postmenopause working, and half our total lives in peri or postmenopause. And to not achieve the optimum for our work life, personal life, relationship life is just, it's just not on. There's things we can do to make that better. And it's great when employers then approach me to say, look, what can we be doing to offer support to our
Mm.
staff? We need to understand more of this. We need to understand how menopause affects women on different levels, and also how it directly relates to us as a company or organization, because clearly going into one company and offering advice may be completely different from the next, and how women operate within that company and the roles they serve.
And so for somebody, I mean, I guess the reason somebody might come to you as an individual potentially could be that they feel that they're just not getting anywhere with their GP, or what could they expect from coming to a consultation, and how does that then sort of feed back into their relationship with their GP surgery? How do those kind of two things work together?
Great question. I think the one thing they get with me is time
Mm,
expertise to explore all aspects of their lives. So a menopause consultation in my clinic is really an hour. That's how much we give for a first consultation. And really, I want to understand where that lady's coming from. Tell me your story is typically what I say. Where have you come from? What is it that's affecting you? And where would you like to get to? And knowing a bit more about that patient and understanding the issues that they're facing, how they've affected them, how long they've been affecting them. Some women choose to bring their partner, their friend, their relative with them, and that's really key. That other listening ear or that other person that's going to contribute to that discussion is key. And then it's really a joint discussion. I might need to examine the patient, but it's also about, what things have you tried? What things have you heard about? Shall we talk about risks and benefits of all the different options available to you? And part of every consultation is looking at lifestyle. What things can you do to help yourself, not just to improve your menopause, but also about long term health consequences? I've got the luxury of a
mm.
consultation to really allow women to take charge of their own lives and optimize these things as much as possible. But first and foremost, the discussions patients have with me are a joint conversation. It's not just me offering a treatment option. It's like, what would you like to do? What do you know? Here's the risks, here's the benefits. How are we going to make this best for you? And I think the nice thing that women go away with is that understanding of exactly what situation they're facing, exactly how the treatment options may affect them in a positive way, but also about any risks of treatment, and also a clearer understanding of what menopause is, where they are in their menopause, and what things might be addressed by treatment and what things might need additional help in coming weeks, months, and how things will change. And I think having that time to really understand a woman's perspective and also understand more about how their menopause is affecting them is just a luxury I adore.
Let's say then that they came away with a private prescription from you. Is that something that they can then sort of take back to their regular GP and have them, maybe with some kind of explanatory notes from you that sort of tells them why you've prescribed this, and then would they be able to take that over?
So, all medication, bar one or two things that I recommend in the private setting, are available on the NHS. So, inevitably, I'm asking GPs to prescribe. I've really facilitated the discussion and advised about a
Right.
management plan, but then their GP can, if they're happy, take over. My patients get an essay, I'm afraid, when they see me with lots of information on, and that letter is copied with their consent, if they wish me to their GP. And that gives their GP an understanding of what I'm doing, because it's really important that we have joint healthcare, and that even if women are choosing to see private specialists in whatever field, that their GP is fully informed, because that might impact on any future medical care their GP is giving, or other medication that they wish to start, and interactions need to be taken into account. So I share that letter with the GP and with any recommendations on. And I have to say, most GPs are more than happy to prescribe the medication because it's licensed, it's regulated, it's approved locally for use. So the majority of hormone therapies are widely available in most areas across the UK. There's one or two things, there's a couple of testosterone products and one or two hormone products that in certain areas are not available yet, but may well be coming on board with local formularies. And in those circumstances, women are offered the choice of a private prescription if they want, or if they want for any aspect of their treatment, they're welcome to get that privately. And that means they can take a private prescription to their local pharmacy. They have to pay a slightly higher charge than an NHS prescription charge, but it's not a huge amount, or they can use an online pharmacy to obtain that medication from. So again, but that's a joint decision. Would you like me to send information to your GP and ask your GP to prescribe these medications, or would you like to get them privately? It's entirely up to the individual patient.
It's good to know that there's flexibility there. So we said that we might do a little bit of menopause myth busting for the main part of the podcast. So What do you think is the biggest misconception that people come to you with? Would you say that it is the breast cancer, or goodness, I can't, it's too risky to go onto HRT?
I would say that's one of them, but I think the biggest one is I've been told I'm not menopausal because my blood tests are normal.
Right.
So it's the women that are between 45 and 55 predominantly who are still having some bleeding, some cycles, who have bloods done and they're normal. And they are invariably normal. There's no benefit to checking hormonal blood levels in women over 45 to diagnose menopause. It's not a useful tool because levels can be high, they can be normal, they can be low. It just depends on when that blood test is taken. The other thing I find is that more younger women, so women in their early 40s to mid 40s, are coming in with, again, normal blood tests, who may have some early perimenopausal symptoms that would benefit from treatment. And again, being told that blood tests are normal, it's not menopause, have some
You're too
antidepressants. This isn't.
young, too young to be
Exactly.
menopausal.
And for a lot of women, under 50, there's no significant increased risk of breast cancer if you use HRT in a younger cohort. We're merely topping you up. We're giving you estrogen that you're not producing in abundance. But compared to somebody who's having no menopausal symptoms, it's not dissimilar the amount of estrogen you're being given to what that person's naturally producing. And so for some women, it's a case of have a go and see. The other thing that is in women over 50, if you use HRT for less than 12 months, there's no increased risk of breast cancer. So for women over 50, it's a case of, well, let's just try. If there's no contraindication and you want to see if this is going to improve your quality of life, have a go. So that's a really common myth. The other myth I've heard is my GP told me I'm still having periods, therefore I can't be menopausal. But perimenopause is a time frame. Anytime you start to develop biochemical, so changes in hormone levels or physical changes like sweats, flushes, brain fog, fatigue, mood swings. I mean, I could go on forever with all the symptoms until you're 12 months past your last period, at which point you're just defined as postmenopausal. But the perimenopause is what, for most women, is the most difficult time when your hormone
Mm.
levels are all over the place. That's not to say postmenopausally things aren't an issue, but they're the women we really want to get hold of. And that can last for 4 to 8 years. So if you're coming in having stopped your periods, you've often missed the boat on all those years where treatment could have really made a difference to quality of life. So that's another common one. The breast cancer one, going back to what you said, is a common misconception. I don't want to take HRT, I will get breast cancer. Well, even if you have taken HRT and you get breast cancer, no one can say your HRT has directly caused your breast cancer.
Mm.
It's about risks and benefits. And we do know certain types of HRT used after the age of 50 increase breast cancer risk slightly. So a baseline risk for women between 50 and 59, if we took 1,000 perfect women who are slim, non-smokers, no family history of breast cancer, not drinking excessive alcohol, doing regular exercise, that baseline perfect group of women, 13 in every 1,000 over a 5-year period, would get breast cancer. And depending on the type of HRT, whether you're having a monthly bleed HRT or a no bleed HRT, the risk goes up by 7 to 10 extra cases of breast cancer per 1,000 per 5 years. But in the real context of breast cancer, it's always worth thinking about lifestyle. So obesity is 10 extra cases per 1,000 women per 5 years. So, for a lot of women, the risk of breast cancer for them is not significant compared to the risk of breast cancer by being obese or smoking or alcohol excess or immobility in a sedentary lifestyle. So a lot of discussion I have with women is about myth busting and saying, look, this is the risk of breast cancer from HRT. This is the risk of breast cancer from, say, your obesity or your smoking or other lifestyle factors. And then this is the risk of breast cancer you may have because of your family history. And it's putting all those into perspective, but it's risk. It's the same as saying if you smoke cigarettes, there's an increased risk of lung cancer. It doesn't always mean that smoking caused your lung cancer. It depends on the type, but there's an increased risk associated. So that's the key thing to bear in mind with the breast cancer risk.
Yeah, so kind of well, it comes back to, as with many things, is to having the information, isn't it, before you make a decision, and kind of having that nuanced risk information, as you said, at least then allows people to make that informed decision. You mentioned testosterone a little bit earlier as being something that can be available both on the NHS and privately, and those sort of the way it's delivered is slightly different. But I think a lot of people are surprised to sort of learn that the role that testosterone does play and how critically important it is actually for women.
Oh gosh, it's so important. So our ovaries produce roughly 50% of our body's testosterone. Our adrenal glands above our kidneys produce the majority of what's left. But when our ovaries aren't functioning normally, our testosterone levels decline. And in particular, it hits women from the sexual function perspective. So libido, arousal, orgasm, all these things are adversely affected by low testosterone levels. And we shouldn't accept that this is the new norm, that we just have to accept a low libido or sexual dissatisfaction. It's a key part of any relationship, and we're living longer, so why shouldn't we still enjoy an active sex life? But I have to say, testosterone provides a lot more than just sexual function improvement. So, women will often notice an improvement in cognitive function, clarity of thought, mood, energy, muscle strength with testosterone. We're not talking about making women grow excessive facial hair, and that's what we're keen to avoid with testosterone therapy. So it does need to be carefully monitored. And at the moment in the UK, testosterone should be prescribed by someone with a menopause expertise. Now, it doesn't have to be a menopause specialist. It just means it has to be prescribed by somebody who knows what they're doing. And a lot of GPs are doing more educational sessions to then become confident to prescribe. We're slightly limited on the NHS in that there's no licensed female product. We use male products designed for men, but tiny, tiny amounts of those. So a man might use 10, 15, 20 times as much as a woman every day. And we're talking about going from a very low level of testosterone menopausally to probably nowhere near what we're aiming for pre-menopausally. So you're not sort of giving someone a testosterone level like they're
Mm.
21 again, but just supplementing their hormone therapy and bringing them up a bit on their testosterone levels. And invariably, that has a positive impact, particularly on libido, but on all those other things like mood, energy, cognitive function. And the improvements are subtle. Women don't suddenly feel like they've got the libido of a teenager again. It is just a subtle improvement. But for some women, it's the cherry on the cake, I like to call it. You're sort of adding that extra level of benefit for women to allow them to function and achieve their full potential.
And so does that have to be kind of layered on top of what would be considered, in inverted commas, normal HRT, and then the testosterone kind of comes in secondary to that? Like you wouldn't get a standalone prescription just for testosterone, presumably.
On the whole, no. So we know that the maximum effects of testosterone achieved by using it in addition to hormone therapy, i.e., estrogen.
Mm.
And that's because our bodies metabolize a proportion of testosterone into estrogen if we're still estrogen deficient. There have
Okay.
been some studies that actually show testosterone on its own without estrogen can still provide benefit, but for the full potential to be achieved, you want some hormone therapy, HRT as we know it, so estrogen and or progesterone with it, alongside for testosterone to be fully effective.
And one of the other things that I've sort of seen people say, or perhaps be told, is that, once they get to a certain point, that their GP might suggest to them that they come off HRT. It's sort of, served its purpose, and then, they don't need to take that anymore. What would you say to that?
Oh, yeah, this is such a common myth as well. There's this sort of, you are 60, you must stop HRT. There's no
You've had your
discussion
lot.
about, yeah, how are you feeling? Is this working? Do you like it? What happens when you wean? And the bottom line is, and there's a lovely statement from the British Menopause Society to echo this, where there's no arbitrary time limit to HRT use. And providing women derive benefit from their therapy, they can continue it longer term, as long as there are no new contraindications or risks that would make it an unsafe choice. Now, it used to be that we had a cut-off at 60, and that was because there was some limited evidence previously that perhaps HRT use beyond the age of 60 increased your heart disease risk. We now know that not to be the case. And younger women under 60, particularly those who start HRT within 10 years of the start of menopause, have a huge benefit for heart disease risk lowering from HRT. We know in women over 60 who start or restart HRT that doesn't apply, but it does not increase the risk. And I think we're going to see more and more women using HRT beyond the age of 60 for quality of life. The bottom line is, you may not need HRT. You may feel completely well without it. It might be that transition phase from whatever age to 60 that's the real rocky time for you, when your hormones are not really playing ball and you need that supplementation. And actually, some women will successfully wean HRT off and stop without any adverse effects. But I'm seeing more and more women who say, look, I've weaned it off. I'm not getting terrible night sweats or flushes, but I just don't feel as well. I'm achy, I'm tired, I'm cognitively not as sharp, and I'm still working. My retirement's probably going to be 70 by the time I get there. So we're spending a huge proportion of our lives working in postmenopause. And for those women, you can justify, as long as you're fit and healthy, you've got no new risk factors, you've not got a female cancer that's driven by estrogen that could be a bad idea with HRT, you've not just had a heart attack, a stroke, or a blood clot, then actually HRT use long term is a good option for many, many women, and more women are asking to continue.
So how would you? I mean, I guess it's almost like you got to try it and see. So if you got to that point, would you sort of taper it off gradually, or sort of stop and then go back on if the sort of symptoms were coming back?
I mean, the best option is to try and wean slowly, because if you withdraw estrogen abruptly, our brains go into overdrive and start to stimulate our ovaries that are no longer working. And that's what often drives some of the symptoms, combined with that sudden withdrawal of estrogen and the estrogen deficiency that follows. So, a gradual reduction is far more preferable to an abrupt withdrawal. And that's often easier by using estrogen through the skin, because it's easier to cut down slowly than a pill that's difficult to break. But there are lower dose oral preparations that you can then switch to. Most women will find that they either get their symptoms back as they're weaning. So it might be they get down to a half dose and they feel fine, and then they wean further and it starts to become a problem. And for some women, it's just about, let's adjust the dose and give you the lowest dose that's giving you benefit and control of your symptoms. For other women, it's they're fine, they stop, and then their symptoms come back after a while. And more
Mm.
patients are coming to me saying, look, actually I stopped it 5 years ago, I've managed, but I'm really not liking how I feel, can I go back on? And again, that's an individual discussion about risks, benefits, what do you want to do. It's about patient choice. It's a completely different entity, menopause, to treating a medical condition where a treatment is going to save your life, and you will have some adverse effect if I don't give you this treatment. Menopause is a joint discussion with the patient. What is affecting you, what options are there, what would you like to do, these are the risks and benefits, and then you make a joint management plan about how best to deal with those.
So, kind of echoing what you were just saying about the sort of, the trial and error and finding the right dose, I think possibly. So, I'm not taking HRT. I've never taken it, but one of the things from kind of researching and sort of talking to people for the podcast is that I think there's perhaps an expectation that you get your HRT and then everything's kind of swimming from there. But it does sound, from what I've been hearing, as though some people don't always react brilliantly to it, and B, for many other people, you kind of need to experiment a little bit to find a dose that is the right one for you, because we're all special, unique people with different symptom kind of combinations. So how does that tend to work in your experience? Are there sort of some people who they get their prescription and off they go, that's fantastic, and then there's sort of a kind of a particular proportion that need a bit more kind of tweaking and kind of oversight?
You've summed it up beautifully. Yeah, there are some ladies who will waltz in after their first appointment and say, this is amazing, everything's better, thank you very much. And I think, wow, that's good. First time on that one. That's the probably more rare group of patients, that you fix everything with just the right dose. But the first thing is, when you take a history from a woman with menopause, is about listening to what they've tried previously, what hormones they've used perhaps as contraceptives in the past, because there's two sides of this, really. The estrogen replacement is often the easier bit to get right, but it's if you've got a uterus and you have to have some progestogen alongside, because
Mm.
otherwise estrogen on its own can cause some womb lining abnormalities. It's the progestogen component that often gives women the side effects, like bloating, like irregular bleeding, like mood change. And it's about listening to the
Okay.
woman and saying, what have you tried previously, what worked well for you, what didn't work so well, and making the right choice. So it isn't a one size fits all with HRT prescribing. And dosage is also completely different. If I meet a woman at 58 who's had 2 or 3 years since the end of their periods and wants some treatment because they're getting debilitating symptoms, the starting dose for that lady will be different to a lady at 45, and the amount she might need might be different. So it is a case of, you've got to review, you've got to reassess, adjust, and tweak. And for some women, it works great for several years. They're absolutely stable, and maybe they've started it in their late 40s. And then when their ovaries really drop off, maybe in their early 50s, I mean, the average age of menopause is around 51 in the UK. So it's quite usual for then requirements to change. And that's
Mhm.
why that regular review is needed. I mean, most women should have at least a once a year review on HRT, even if they're completely stable. But in the first 6 to 12 months, it's normal to expect 2 or 3 reviews. Get your HRT sorted, get it right, feel well, everything's optimized. Okay, now we'll see you annually, but come back if things are not right. Let's reassess. Let me know if you have any abnormal bleeding or side effects. So that's where it's not an exact science and it's a bit more tricky, and you've got to listen and adjust. And likewise with the weaning down, if women do want to wean down, sometimes it's a case of where are you now? How are you feeling? Do we need to adjust again? What's changing for you?
And so I know it is very hard to generalize, but let's say that somebody has just started HRT. If they were going to have a sort of um, or find that they weren't kind of getting on with it as well as they would hope, would you expect to see that reasonably quickly, sort of within the first couple of months?
Yeah, I mean, I normally review my ladies about 3 months after they start, and I often give an advice plan that starts with a low dose estrogen if they're starting it for the first time and gradually build up. Because if you give women too much estrogen too quickly, their breasts feel really tender, they get
Mm.
headaches, they feel quite sick. And if you give a whopping great big dose of estrogen and all these adverse effects happen, then it's quite reasonable. A woman's going to go, well, I'm not taking this stuff. This is
Yeah.
dreadful, and pull back. So just gentle introduction, but it's also about explanation. It's not just here's a prescription, off you go. It's this is what I'm agreed we should try. These are the likely side effects. This is what I'm expecting you to feel better and how long it will take for you to feel better. So it's all about managing expectations, because it's unusual for me to give a prescription within a month women feel top of the world. It's normal for improvement to be noticed within the first 4 to 6 weeks. So estrogen deficiency can be quite easily corrected, and women start to feel better around the 4 to 6 week mark. Some women feel better much, much more rapidly than that. But it's usually the side effects are within the first 3 months, and often by the time women come back to see me at 3 months, they've had a few little niggles in the first couple of months, but they've ironed themselves out because they've persisted, and then they know they've got that follow-up to go through. So things like a little bit of minor bleeding or a little bit of breast tenderness tends to have eased off.
So that will kind of settle as your body gets used again to the sort
Yeah.
of new kind of hormone levels, and
Yeah,
that
it
will
just takes a
settle down.
while for your body to accommodate. It's a new medication going in. Your hormone levels need to adjust, so just give it a little bit of time and be patient.
There were quite a few headlines recently about products being available sort of over the counter. That's not specifically the sort of the HRT itself. That was more talking, I think, about topical estrogen.
Yes, spot on. So, obviously, an HRT patient taking HRT, it's got to be a very careful discussion looking at risks, benefits, safety. The product they were looking at is a vaginal preparation of estrogen that comes in a little pessary. And on the whole, this is incredibly safe, which is why it's been proposed to be rebranded as a non prescription item and over the counter product. And even women with breast cancer can use low dose vaginal estrogen because so little of it gets into the bloodstream. It doesn't increase the risk of recurrence from breast cancer. But I have to say, I spoke on the radio about the over the counter headlines because I think even though it may be limiting what women can access over the counter, and a specific medication that's obviously safe and could be licensed in that way. For some women, it's the start of a conversation. It might be, I want some of the vaginal estrogen I can get over the counter. And the pharmacist then says, okay, what symptoms are you getting? Is it just vaginal
Mm.
dryness and soreness and painful intercourse? Or is there something else going on? And actually, that might be a great opportunity for women to be given information and directed to the right healthcare professional to seek further advice and information and support if they've got other symptoms, not just the vaginal side.
Any other sort of major myths that you can think of?
Well, the other one is I'm going to delay my menopause by taking HRT. That's a really good one. So you're not delaying anything. Your menopause happens. Your ovaries have a finite amount of eggs, follicles in their lifetime, and when they've all run out, that's when menopause happens. You've run out of eggs. that happens regardless of what you're doing with the hormones. That if you use HRT, it's not delaying what's happening in your natural ovarian function. So you're not delaying anything. You're merely replacing the estrogen you're not producing in abundance, and preventing the symptoms that are associated with estrogen deficiency and ovarian function declining. So that's a key thing for women. You're not going to postpone menopause. You're not delaying it. You're not preventing the inevitable. It's about managing those symptoms associated with the loss of ovarian function adequately. The other one that's quite common is all my symptoms will come back when I stop. And whilst there are some women who need to continue using HRT for symptom control, a lot of women successfully wean HRT and stop at whatever age they choose. Again, joint discussion with a healthcare professional. But I like to emphasize to women that, if you use HRT within 10 years of the onset of symptoms and for any period of time up to the age of 60, that lowered risk of heart disease, lowered risk of bone density loss, lowered risk of bowel cancer and diabetes apply. They're often not in the headlines. It's breast cancer that gets the headline as a negative about HRT, but so many positives as well. I mean, heart disease has far-reaching effects. 26,000 women in the UK roughly each year have heart disease related issues or deaths from heart disease. So it's really important we look at those risk factors, particularly if you've got family history or there's other things going on that put you at increased risk.
One final question before we wrap up, and you might not have the answer to this, but it is something that has always kind of made me wonder. Some lucky souls seem to get through this with no symptoms, or at least say that they have no symptoms. Do we know why that is?
Not really. There's a genetic predisposition. So often one woman's menopause is similar to her mum, grandmother, sister. I just think some women are extremely lucky. It depends on a whole host of factors. It depends on why menopause is happening at a particular age. We often find that women who may be a bit older when they have their menopause, it can be shorter and sharper, but it's so variable. Particularly with flushes and sweats, they're linked with high levels of follicle stimulating hormone, and women who often have a very abrupt menopause, it can be more marked. But it's so difficult to predict, and gosh, yeah, it'd be great to know or predict how bad your menopause is going to be. That would be wonderful.
I'll just take those 3 years off, and
Yeah,
I'll go take
exactly.
myself off to a desert island for a bit, away from everyone else.
Oh, can I come?
Oh, Katie, thank you so much for giving up some of your time, because I know how busy you are. Yeah, it's been lovely to talk to you again. Thank you so much.
It's been a pleasure, Emma. Thank you.
You've been listening to the Middling Along podcast. Do remember to subscribe to be notified when our next episode is live. And why not visit the blog at www.middlingalong.com to sign up to my newsletter as well. I do hope you enjoyed listening today. If you did, I'd be really grateful if you would consider leaving a short review, as that helps people find the podcast and helps get it noticed. Hope you can join us next time. Goodbye for now.